Hi, and welcome to Humanity RX, where we are sharing stories that highlight the human side of healthcare and bringing you life lessons from the bedside. We are your hosts, Jenny,
Tova,
and Jonathan,
and we're glad you're here. Our guest today is Callie Dayton. Callie, we are really excited to have you here today. You do so much advocating and so much work really putting a light on this human side of healthcare and critical illness in particular. Can you introduce yourself a little bit more to the audience and tell us about your journey in healthcare?
Absolutely. I'm a nurse practitioner. My specialty is critical care. And my journey to where I'm at now started in 2012 when I interviewed into my first ICU job. And they asked me immediately if I would be willing to walk patients that are intubated on ventilators. So if they have breathing tubes, instead of being in a coma, they would be awake and walking around the halls. And being so new to the field, I just pretended like I knew what that was and just excitedly said, yeah, absolutely. But admitted that they'd have to teach me everything. And when I was hired there, no one made a big deal out of the fact that almost every patient on a ventilator was awake, writing on a clipboard, whiteboard, communicating their needs, sitting in the chair, and even walking around the halls if they were able to. And so I did that for a few years, thinking that that was normal ICU care. And then I became a travel nurse, and I was pretty surprised to find everywhere else in the next 11 ICUs that I worked in, patients were automatically sedated into medically induced comas. I returned back to that first ICU after a few years during my graduate studies and was almost shocked again to adjust to that whole new culture of, yes, these are very sick patients. And this is so much nicer for me as a nurse to know who they are, to have human connections. I struggled in these other environments because I was working so hard, but didn't get to really connect with my patients like I did in the first ICU. I was finally able to, again, understand what their preferences were, what songs they liked, what food they were looking forward to eating after they got the breathing tube out, whether they wanted this kind of care or not, why they were fighting to live. All these little things that make us so human, I was able to experience that with my patients, and I had missed that when I was previously taking care of patients that were comatose. And that really impressed me and made me wonder, why didn't these other ICUs do this kind of care? Why didn't anyone believe me when I tried to explain that my patients were awake and walking? They couldn't even imagine that. And so that led me to really explore the research, and I came to understand the history of this culture of how we manage patients on ventilators in the ICU. And it really led me to start my podcast, Walking Home from the ICU, to guide ICU clinicians to reconnect with their why they entered medicine, why we need to treat patients as the valuable humans that they are, why we need to give them the ability to be autonomous and communicative even during critical illness, even when they're on a ventilator. And it's been really fun throughout the years of doing my podcast to listen to survivors share their side of the experience in the ICU, and then to listen to clinicians talk about how much this transformation in care has enhanced their clinical experience, their career fulfillment, how much they love seeing patients survive at higher rates, but also leave in much better conditions, being able to walk out the doors, being able to know their patients for who they are and help them succeed and have that deep connection has led many clinicians to actually stay in critical care during a time in which many clinicians are leaving.
Why do so many ICUs still operate under this model where patients don't really get offered a choice and they're sedated?
Oh, that's a multifactorial problem. A lot of it comes to the fact that we are all products of our experience and training. So today in 2025, that's why most clinicians do that, is because that's all they know. In the 1990s, when we were experimenting with how to care for patients with acute respiratory distress syndrome, which is a condition when the lungs are responding to some kind of energy, the lungs are responding to some kind of injury and become very inflamed and very stiff. And so the idea during the 90s was to give those lungs lots of volume and lots of pressure from the ventilator. And these were old ventilators, old tubes. There's just no way people could tolerate that, stay able to be compliant with the ventilator. So that's when they started bringing up medications from the operating room to keep them comatose, just like we do in the OR. And we thought, well, it causes amnesia during surgery. It must be great. And we noticed that their eyes were closed, that they weren't moving. So the assumption was that they were sleeping. And again, in the 90s, this was experimental. And years later, we looked back and realized that a lot of those people died. And there was a strong correlation between those sedatives, how much they got, how long they got, and their outcomes like their survival rates, brain injuries, trauma that they had afterwards. So we came to learn that these patients are not sleeping. They cannot get real sleep. And when they're not sleeping, they often have very vivid hallucinations that are very graphic and traumatizing. So for the clinician side of the bed, when you have sedation running, they look like they're sleeping and calm and peaceful. When you take sedation off, they get agitated and wild, and they're trying to pull out their breathing tube and their lines, and they're trying to climb out of bed or hit the clinicians. From the patient perspective, they tell me that, no, I thought there was a snake down my throat. I thought I was kidnapped. I thought I was being sexually assaulted. But the clinicians are not taught that. They just think, oh, they're uncomfortable. And then they see when they turn sedation back on, they go, quote, back to sleep. So the perception is that it is humane to have them sedated, that they don't experience anything, feel anything, they won't remember anything. We're protecting them and keeping them more comfortable. Survivors tell you otherwise, but there hasn't been a proper bridge between patients, survivors, and clinicians. And then they've never been trained on how else to treat patients. So in my Awake and Walking ICU, it wasn't that just that we didn't give them sedation automatically. It was that we did all these other things in place of it, like communicating with patients, having them tell us what they're experiencing and treating their pain, managing their anxiety, getting them up out of bed instead of leaving them to be trapped and strapped down to a bed. So it's a humanized care that then helps patients be awake and compliant and calm during a very uncomfortable experience of being on a ventilator. Those are skills and approaches that most clinicians are not trained. So they're not trying to hurt people. They seriously just do not know.
That is huge. And I think that there's such a lack of understanding because these patients, again, like haven't been able to communicate this, right? And there has been no one to be that voice for them. But what really struck me is you're saying from a clinician perspective, how much nicer it is for you to be able to also work with these patients, because we all know, like as a patient, you're very vulnerable. You want to be heard, you want to be seen, you want to have that voice. But for us as clinicians, it's also important to hear their voice, right? To see them as they are, as this, like you said, valuable person is a huge deal, right? In the way that you can provide care.
And this delirium not only happens in the ICU, but also on the acute care floors. So then, though they may seem like they're calm and comfortable while the sedation is going, while they're in the coma, afterwards, it can be days or weeks of very challenging care as they are confused. They're impulsive. A lot of times they're combative or they're very lethargic. They depend on the caregivers entirely for all of their care, and it's not fun. It's very stressful. And it increases their time in the ICU by almost 5 days, in the hospital by almost 7 days. And a lot of times they end up going to care facilities. And so it's all just very depressing. It's very different when someone is awake, writing, thank you so much. Here's what I need. Awesome. Not everyone's like, I love this tube. Thank you so much. Don't ever take it out, right? But they're not thrashing like they are after they've been sedated. And so that's the contrast is I can help them through a challenging time. I minimize their time here. I give them back lives worth living. I get to know who they are. We get to develop meaningful relationships. So it's hard work either way, but this work is fulfilling and worth it.
Any particular memory of like those first few weeks of this new thing that you were trying in the ICU and maybe pushback you got from administration or a specific patient that maybe it was like, wow, I can trace that person as being like the first patient that we worked with on something like this?
When I started my first job, they had already been caring for patients this way for almost 15 years. So even in 2012, it was old news in that ICU. So no one made a big deal out of it. So I could not tell you who the first were. So I didn't realize how significant it was. Now, when I train teams, they absolutely know they're first. And those are such special experiences. And I always encourage teams to write them down, to get patients to sign the waiver so they can take pictures and document that and make a big deal out of it, because it really is a big deal. 6 months, a year later, in those same teams that were so nervous those first few times, now it's all just routine. And when I ask them for special stories, they're like, it's just normal now. So I always invite them to not lose the magic of it, because those first few times, it's like believing the earth was square the entire time and realizing it was round. Seeing someone awake and communicating on a ventilator is just mind-blowing for most clinicians.
Yeah, and amazing for the patients and their family members. Is there a specific story that comes to mind for you that had like a really lasting impact on you?
Yeah, I have so many. I worked in that Awake and Walking ICU for 7 years. So I wish that I had realized what I would be doing in the future. So I wish I'd had a journal, written those things down. But one moment that really had a ripple out effect throughout the rest of my career was when I had returned back to that first ICU after doing traveling. Once I was in grad school. At one point, I was in the cafeteria of a hospital. I was in the float pool, so I was working all over the city. And someone yelled at me from across the cafeteria and said, "Hey, I thought I knew you." And I turned around and it was this woman that looked so familiar, and I just couldn't put my finger on it, but she had some very distinct physical features. And I was just going through the filing cabinets of my brain. And she said, "You were my nurse in the ICU." And I was like, "Oh, okay." And suddenly I could start to see the room, start to remember the ventilator. And she said, "You made me walk when I was scared and anxious and tired and did not want to, and I thought I hated you." And I was like, and then it all came back to me. I remembered her just trembling, sitting at the edge of the bed. At baseline, she used a motorized scooter for a lot of her mobility. She was very weak. She had severe pneumonia. She was intubated. But we knew that if we didn't walk her, she was probably going to end up in a nursing home. And she kept writing on her clipboard, "I don't want to go to a nursing home. I don't want to go to a nursing home." And she was able to tell me via pen and paper about her partner, her dogs, what she was looking forward to going home. And I would use that as leverage to say, if you stay in bed, that's where you will stay. If you want to go home, you got to do this. It was tough love. And so I was remembering all this stuff in that moment of like, yeah, I did really push you. And I went to explain, and suddenly I realized that she had me in this bear hug. And she said, "But you saved my life, and I have loved you ever since." And this was years after the fact. And I really, took a lot of memory jostling to remember her, but she remembered me so distinctly because I'd pushed her through those imperative moments. And I continue to think about that throughout the years, that those words, "You saved my life." And I think in this ICU, especially, we think about the ventilator, certain medications. I mean, we are literally keeping the blood running, the pulse going. That's saving a life in the ICU. But I don't think that's what she was talking about. That's not why she was hugging me. That's not why she remembered me. It wasn't just because I kept the ventilator going. It's because I made her walk and work hard to preserve her quality of life and go back to the life she lived before. And to her, she understood way before I did that saving a life in the ICU is saving and preserving the quality of life that mattered to her. And so that was a very instrumental moment in what I do now as a consultant and revolutionist trying to transform critical care medicine in general. She was a great teacher.
I love that you call yourself a revolutionist. I heard you say that on your podcast too. Like, that's so cool. We need a healthcare revolution.
Absolutely. Absolutely. And that's like the best descriptor for these people that are working on this in their ICUs throughout the world. I mean, this is a whole movement. It's not new. Again, my ICU has been doing this since the 90s, but those that are bringing these changes are up against so much. I'm actually doing an episode about them, about the opposition, the harassment, the abuse that they've suffered while pushing for these changes. It's incredible how much resistance there is to what I would call humanizing the ICU. But once they get it, once people actually experience it, even the biggest resistors become the strongest champions. Because at their core, clinicians want to do the right thing for their patients. They just need to be convinced that this is the right thing and have the confidence to know how to do it. And then they're unstoppable.
I wanted to say that I think one of the worst phrases in healthcare is, "But we've always done it this way," right?
It's a lethal phrase.
We hear that all the time. We're like, it's fine. We've always done it this way. And especially in a field like medicine, where constantly we have new research and new information, and we're learning all these things. Like, how can you always do it the same way? You can't.
Medicine is a field of evolution.
Yes.
And it's been amazing to study some of the past revolutionists, Jens Semmelweis that created hand washing, Elizabeth Kinney that created physical therapy for polio kids. Instead of splinting and immobilizing those limbs, she's like, no, let's just exercise them. Let's get them using those muscles rather than impairing them. And so all these people met resistance. So it's not surprising. It's frustrating, but it's not surprising. But I think we're in such a good position right now to use our resources like social media, the way we can educate, the way we can spread this message that we couldn't back in the 90s and early 2000s. I think this is when it's really going to turn a corner.
Yeah, and we're lucky to have you in the lead. We need people who have the fire and the will and the confidence to lead.
I'm certainly not alone. I'm not, I may be the most vocal about this right now and really putting my face in the line of fire, but there were many revolutionists before me and many with me at this time.
One of my mentors through grad school, and he used to go visit as a clinician, go to a lot of LTACs and long-term acute care. And he would tell me how just the weird feeling of walking through an LTAC is just so quiet. And you just hear like the little beepings of the ventilator, right? And it's sad. It's like heartbreaking and crushing that all these people who are there long-term are just kind of in bed. They're probably sedated. I mean, granted, I'm sure they have long-term injuries, but it's finding people like yourself, and you remind me a lot of certain people who were very influential in my career as I was starting, who always believed in those people, that they had something more in them than, like let's wake them up and walk them. And there's a whole lot more we could do for them.
I'm very passionate about rehabilitating our patients, protecting the muscle mass, the cognition, the quality of life, their function before we lose it. So in LTACs, it's really hard because you see a lot of patients that have lost it during their time in the hospital. And then there's a lot of staffing challenges in that setting that make it hard to provide the kind of care needed to really get them back on their feet. But yeah, it's a very important population. A lot of people that work in LTACs, I wish they would come into the ICUs because I think they would bring a lot of insight that we don't usually have when we only work in the ICU.
I work at an LTAC.
Okay. So you get it.
But also I want to kind of go back to the point that you made. I know, Kelly, Dr. Wes Eli, and I was reading his book recently, and he talks about, well, we're saving lives, right? You're saving these people, but what are you saving them to? Because the quality of life is so important, right? And I always tell my family, I'm like, listen, if I'm so sick that I'm not going to make it to be like the functional person that I am, just let me go. Because everybody's different in their wishes, obviously, but that quality of life is so important, right? You're still alive, but you're not yourself. And then you have a whole host of other things that you're dealing with. And so putting an emphasis on that quality of life is huge. It should be front and center in everyone's mind.
I think everyone got into medicine to prevent suffering and save lives. In our core, that's what we want. Just the current culture and routines don't necessarily facilitate that all the time. So for me, it's been really fun to watch these revolutionists learn this information, catch the vision, and understand by giving someone a pen and paper right after we place the breathing tube, I am protecting them from a brain injury. By walking them within the first 2 days after intubation, I'm improving their cognition by 20%. A year after discharge, I'm preserving their ability to walk out the doors, to get themselves to the bathroom, to go golfing, to garden. Like, they see this big picture, and now they realize they have so much control and impact on that. And that's what drives them. It's really hard when you treat patients that come in with conditions that you can't reverse. You're working to treat. You can't roll back the time and prevent the car accident or whatnot. But what you do every day on your shift can greatly determine not only if they survive, but what kind of lives they go on to live. And that is really empowering in an environment where there's a lot of unmodifiable harm happening. There's a lot we can do to protect him from the things that could happen.
Cal, you've given us about 15 prescriptions for humanity. And we always like to end the show with something, if you can give a prescription to humanity for those listening. And that may cover healthcare providers, caregivers, patients who are going through a healthcare journey. Just something that you can leave with us today.
No matter what position you're in healthcare, remember that care requires customization, personalization. So if you are a caregiver, clinician, see your patients as who they are, not just as a room number or a diagnosis, but dig deeper. What was their family background? What did they do for a career? What did they like to do as hobbies? What were they doing functionally? When I train teams, I have them share information during their rounding process when they present all the medical information, just as important. And right away, they need to say, this is a 67-year-old gardener that loves to play pickleball and is a retired engineer. And then go on to the medical stuff so that we are now framing someone as, here's what they were physically functionally doing. Here's what they love to do, or how many kids they have, something personal, so that we're then catering all of our care and our focus is getting them back to where they came from. If you're a loved one in the healthcare system advocating for a patient, bring in pictures. Tell the clinicians about who your loved one is. Help guide their focus to returning them back to where they came from. We are in a really busy, chaotic, broken system, but as we focus on the humanistic part of our care, everything else will become even more evidence-based. It's interesting how humanity and medicine come together. It's not one or the other, and it can't be one without the other.
Kelly, thank you. And thank you for the reminder to keep it human. Thank you for the inspirational work that you do. And thank you for being here with us today.
Thank you for listening to Humanity RX. We hope today's conversation gave you something to think about and maybe even feel a little more connected to the human experience. To find out more about our guest, please find more information in our show notes. Humanity RX is created, written, and produced by the three of us, Jenny, Tova, and Jonathan. If you enjoyed this episode, we'd love it if you subscribed, left a review, or shared it with someone who needs a little dose of humanity. You can find us on Instagram at HumanityRxPod or LinkedIn at HumanityRx. Until next time, be good to yourselves and each other.